Hello, and welcome to Ask the Professionals Q&A. My name is Heidi Sittelmeyer, and I am the Director of Online and Community Connections here at the Arthritis Foundation. I facilitate a Live Yes Connect group, and I am a patient living with arthritis for well over 50 years. I have juvenile arthritis persisting into adulthood, and now also osteoarthritis. Ask the Professionals Q&A is an interactive video series where we solicit questions from the arthritis patient community and then bring those questions into leading experts to help get our questions answered. I have the pleasure of having Dr. Terrence Starrs with us for Ask the Professionals. Now, Dr. Starrs is a veteran rheumatologist. He's a clinical professor of medicine and occupational therapy in the Division of Rheumatology and Clinical Immunology at the University of Pittsburgh School of Medicine and of Health and Rehabilitation Services. He treats all types of rheumatoid arthritis, fibromyalgia, and low back disorders. Dr. Starrs is an active member of the American College of Rheumatology and is a past president of the Pennsylvania Rheumatology Society. He has authored many rheumatology journal articles and received many top awards for his board and community service, including from the national and regional chapters of the Arthritis Foundation. So welcome, Dr. Starrs.
Oh, thank you for your kind words. It's great to be here. It's a sunny day here in Pittsburgh.
Awesome. All right, well, why don't we jump in, because we've got a lot of questions today. So let me start with our first question. Can you give us a brief overview of the different types of arthritis pain and some tips on how to interrupt the pain cycle?
Absolutely. If we think of the basic concept of what exactly is pain, and that is a challenge because pain really is the cardinal manifestation of the over 100 named musculoskeletal problems. And I think by understanding this definition, it really helps us to frame a understanding of the different types of arthritis, as well as the different manifestations. So pain is really the warning signal that our body has to tell us that something is wrong. And when we think about it within the musculoskeletal system, there are a series of different parts of the pain processing that we have. And this will help us when we think of this to really, again, understand about how we diagnose the different kinds of arthritis and how we treat them. So when we think about pain, we have what we call pain generators. And those are different parts of the musculoskeletal system where the pain comes from. Think about, for example, if you pinch your finger right here, there is a stimulation of receptors, of specialized areas that sense the pain. And then that pain signal is sent on nerves. And I think a good way to understand how nerves work is they're really like electrical cords, because the impulses are sent electrically. And it comes along the nerve and it comes right here to our spinal cord. And the spinal cord is a place where we then relay that information up to our brain. And we have parts of our brain where we feel the pain, but something that we have to remember is that in addition to that part of the brain, the signal from the pain generator also can go to the front part of our brain, and that's where a number of different functions occur. One of which is the emotions of pain are added. Secondly, that's where our mood is controlled, whether we're discouraged or depressed or happy. That's where our sleep is controlled, and sleep becomes a very important part of kind of the whole pain process. And also hormones are regulated in that frontal part of our brain. So that whole constellation. So to return to the question of the different kinds of arthritis, we have to look at the pain generators. We have to look at that joint. And just remember, the joint is where bones come together. And here in our finger, we have a joint here and a joint here and a joint here. We have the bones. On the surface of bones is the cartilage, which is the cushion between the two sides. Surrounding the joint, we have a capsule. It's like a housing that goes around. And there's a joint lining called the synovium, synovium. And that's what makes the joint fluid, which is the oil or lubricant for the joint, as well as that's where joints are nourished. That's where the cartilage is nourished. And then we have surrounding there the tendons, the muscles, and the ligaments. So the different kinds of arthritis affect different parts of those joints. And in our discussion today, we'll talk as we go through about the different kinds of arthritis and help you to understand.
Great, awesome. So, one of the questions we got was, why do I still have pain even though my disease activity and inflammation are under control?
Right. So when we think about the different musculoskeletal problems, we can kind of put them into categories. One category is the wear and tear type of arthritis, osteoarthritis. And that's where that cartilage, that shock absorbing surface on the bones wears away. And then there's some reactive changes that occur in the bones. That's where we get bone osteophytes or spurs. Now, when we contrast that to rheumatoid arthritis is an inflammatory kind of problem. And inflammation can be thought of as when you would cut yourself, how it's red on either side. Well, that's what inflammation is. That's our body's attempt to handle something that's irritating a part of our body and to heal it up. In rheumatoid arthritis, it affects the joints. And so the question you ask is a very important one, is that why, when we control, for example, rheumatoid arthritis, why can there still be pain? Well, there are several answers, or several parts to that answer. One is that there can still be a low level of irritation. And that's the same in terms of with the osteoarthritis. When the joints are injured, the process can be stabilized, but still there are the changes in joints, and that still can generate the pain. But another answer is, as we explained, that the pain information goes to our brain, and an area of really very intense research is what goes on with our pain. Why, for example, in acute pain, such as with low back pain or with gout, why does the pain stop in most instances? Versus the whole situation frequently we have with arthritis where it persists, it becomes chronic, lasting, months or more. And so the whole process of having that information in our brain, it can get very sensitized. And sometimes we get into a situation where we have what's called central sensitization or central amplification. That just means the volume control is turned up. So one of the bottom lines is, working with your healthcare professionals, we need to help understand whether the disease process is still active or whether there is some element in terms of how we're processing pain, which could be responsible for the ongoing symptoms.
Great, thank you. And that sort of ties into the next question, which was, why does pain come and go?
Right, and and that is so important. As a rheumatologist, I deal with pain because, as I mentioned to you, pain is really the cardinal manifestation. And why does it kind of come and go? Something I tell patients that I think is pretty useful is that there are factors involved with the pain, that whole pain continuation. And I give them the analogy of like a hinge on a door. And if you keep using that hinge or overusing it, it puts a lot more stress on it. And so one of the challenges with arthritis is that if there is a inflammation or wear and tear type of changes in a joint, we have to be really careful because those changes can be aggravated by movement. Example I give patients as well, it's like when we cut ourselves, we put a Band-Aid on. When you break a bone, you put a cast on it so that we limit the movement or the activity, and that promotes healing. And so it's a difficult challenge for us to make modifications of our activities of daily living so as not to aggravate. You know, we have a term that it's called triggering tasks. What is it that aggravates our joint symptoms? What is it that pulls that trigger that causes an aggravation to occur? And, you know, that's something that you, the patient, has to really recognize and try to understand and to make modifications. It's hard to make modifications to, not for me, of course, but it's hard for all of us to modify how we do things. And the last thing I want to emphasize to you is when we talk about keeping our muscles strong, remember that our muscles are the supporting structures of our body and that they help to reduce stress on our joints. So if we think about walking up and down the stairs, for example, for every 1 pound of body weight, because of the physics of how that all works, there are 4 to 8 pounds of pressure placed on our knee. Now, if we have strong muscles down there, that helps to decrease the amount of stress on your joints. That's why physical therapy measures done in a proper manner to keep our muscles strong really can help significantly reduce the discomfort.
Great, thank you. Now, you mentioned sleep earlier, so I'd like to ask a couple of questions around sleep. So really, how can someone get better sleep with pain? You know, there's that tossing and turning that happens, or shifting, trying to find that comfortable position.
So your question really, Heidi, is so correct. You know, sleep is it's a complex part of our physiology. You know, we spend almost a third of our day in sleep. And, you know, we think of it as being something that's inactive, but that's not the truth. It's a very active process. You know, think about dreaming, thinking about as we go into deeper levels of sleep. And we call those deeper levels restorative sleep. You know, you hear the phrase a good night's sleep, and that is true. And I think all of you know that, as all of us know, as we get a little older, I mean, I need a good night's sleep. You know, when I was an intern, I could stay up all night and, you know, work the next day. I must say, I need to have a little sleep.
Just a little harder, yes.
Yes. And so, but the problem is that we need to think, first of all, about sleep hygiene, you know, and you need to kind of set a time of day where we sleep. We need to make sure that they're not distractions. You know, we have 2 cats, and you know, when the cats come up on the bed, or you know, we don't have dogs, but if a dog or whatever, you know, we need to make sure that we go to bed at the right time. You know, going to bed too late, we need to make sure that we don't sleep during the day. You know, unfortunately, that throws off the normal rhythms of our body when we sleep, you know, too much during the day. Physical activity can help during the day, but we don't want to be too physically active before we try to go to sleep. You know, we certainly don't want to have the television on, you know, those are kinds of things. And so the important thing is we want to try to look at the normal physiology of sleep. And if you go online and kind of look it up, you'll see that those different factors, and, you know, the ones I just summarized are the major ones. If people, though, are really having a situation where they're not having a good sleep, you know, there are sleep studies that can be done. One dilemma, by the way, if you're having pain, it's hard to get comfortable. And when it's hard to get comfortable, then it gets into a vicious cycle there, and then we may not sleep well. So it's not a simple problem. And, you know, a lot of the population does have problems sleeping.
Yeah. And I think I know from my own personal experience and the work I've done with a number of patients,
Mhm.
there is that vicious cycle where you can't get to the restorative sleep, where you're tossing and turning, trying to protect a joint to make it, less painful. Any suggestions on best
Well,
position
it's
if you've got
interesting.
a joint that's
You
not
need to try, when we're going to bed, you want to try to decrease the amount of intellectual activity going on, to kind of go into a more primitive part of your kind of brain functioning. If you think about counting sheep, what does that do? It just gives you something very rote to do, of counting the sheep and jumping over the fence. Something I do is that, I try to think of, kind of some activity, whether it was gardening or whether if I was playing golf or whatever, I just kind of go, gee, I walk up to the first tee and I put my little tee in the ground, and you start doing that and you get into a very, you're not doing a lot of thinking. And, some people really just try to think of nothing, of just think of kind of the white or dark screen and just try to decrease. The other is to actually consciously relax your body. Start at, whether you start at your head or your feet, and just kind of go down and try to have your body muscles just relax. And by doing so, those types of activities can help uh, enhance your getting to sleep and staying asleep. One of the dilemmas with sleeping medicines is that they may not really cause a normal restorative sleep. There are some medicines, kind of some of the over the counter, again, depending on age and all the rest, the diphenhydramine, the Benadryl, that's what's in most of the sleep aids, the antihistamines, they actually do work for some people. There are some medicines that are not habituated. One of the problems with some of the medicines really is that they do work, but they kind of anesthetize you, and that really is not a restorative sleep.
And how about any supplements?
Well, I mean, some people like melatonin, and it's okay. Does it work in everybody? No. Some people like Benadryl. It's you have to be very careful, with the dose, and sometimes using the children's dose, that comes in 5 milligrams. The typical diphenhydramine Benadryl is 25 milligrams, and it can make you a little groggy, and so that's why there is some concern. So you need to check with your doctor and make sure that you can tolerate one of those.
Great, thank you. So switching gears. So what's better for painful joints, hot or cold?
Hot or cold? Well, it's interesting. Believe it or not, you have to look at what they do. Heat kind of dilates up, and you have to be careful with either of them, though, because if you sit or lie on a sleeping pad or, on an ice pack, I mean, you can actually get burns, either hot burns or cold burns. And so it's important to think about ice is really a constrictor. And so if there's an injury and swelling, that is best. The heat is more of a dilator. It's a muscle relaxant. Some people actually use a contrast where they put a little ice on for a few minutes and then follow it with heat. And so, there's not a perfect answer. Some people like cold more than they like heat. Some people like heat more than they like cold. Yes, I know. I agree, Heidi. I'm a hot person. I like the heat.
I like the heat too. That's my go-to. All right, great. Well, let's switch gears. So, and I'm, as somebody who lives with rheumatoid arthritis for a long time, I definitely know about this. So, how much pain, this is a great question, how much pain should you tolerate during daily activities before it causes more damage? Like,
Well, that's an important question, and that's why I like the definition of pain. It is a warning signal to tell you that there's a problem. That's why one has to be careful with certain kinds of pain medicines, because it takes away that warning signal or can modify it. So it really does allow you to overdo it. So any of these things are a balance. And so, you need to work with your doctors to understand exactly where the pain is coming from, and to try a concept we have in rheumatology is treat to target. We try to target exactly what the problem is and to then focus on decreasing that or hopefully resolving it so that that pain generation can be reduced. That's why, and I know it sounds simplistic, but, some modification of activities of daily living really does make a difference.
Right. Yeah, because I know there's times where I'll push through the pain, and just muscle through it. But then there is that concern in the back of the mind, like, am I doing more damage
Right,
by
right.
pushing,
Yeah, but
right?
you have to be careful. It's not no pain, no gain. I mean, I discourage that quite honestly, but that's why keeping your muscles strong helps reduce stresses on your joints, and that's a really an important concept as well.
Right, thank you. So let's talk a little bit more like around treatment. How does like one go about talking to their doctor about CBD or THC products?
You know, if one thinks about this, and something I always emphasize to patients, I ask all my new patients, I say, who's in charge of your care? And, really half the patients say to me, Doctor, you are. And I say, no, you, the patient, you are in charge. You are the captain. You are driving the bus. Significant others in your life are the first mates. And they're very important in this whole process. That's why their understanding, their participation in the kind of the whole total management is very important. It's frustrating to have somebody you care about having a medical problem. So you have to be really careful in that regard. We, the healthcare professionals, though, are we're the ones who are your navigators. We help. And so when we take a look at different treatments, we need to take a look at the following general concepts. We need to look at what the disease process is. Is it a mechanical process like osteoarthritis with wear and tear? Is it a process like rheumatoid arthritis with inflammation occurring in the joint lining and other parts of the joint? Is it a situation like fibromyalgia where the volume control is really turned up? And actually, with rheumatoid arthritis and with osteoarthritis, as well as the other kinds of arthritis, there can be an element of central amplification with them as well. And so in looking at that, then you look at the treatment, and you have to see, what does the treatment do? And how does that mechanism of action of the treatment influence the disease process? And so given that situation, then we look at studies to see whether the scientific evidence supports exactly what to do with this. We have to look at the good effects of the treatment, the side effects, and really what if nothing's done at all. If we look at treatments, like the the CBD, the THC products, one great challenge with them is that they really, there's such a limited amount of data on them because they're highly scheduled drugs, and so they now there's a little more research, but still there's a great paucity of research to tell us what the right answer is. From a targeting of disease processes, certainly those preparations work on kind of more the central processing, our brain and all the rest. And there is an issue. The issue being is it doesn't necessarily target the disease process. They are not anti-inflammatory. They do not influence the inflammation with rheumatoid arthritis. They don't influence the wear and tear changes that occur in association with osteoarthritis. And so it is a dilemma. And so, when patients ask about it, it's something that we have to think about within that context. There really is a significant expense associated with it. And I always emphasize to people that you need to know what the diagnosis is. You need to know where the pain is coming from. What's the pain generation? You need to look at that whole processing mechanism and then really try to determine how to most effectively deal with that. So, there's not a perfect answer to it. But the one challenge that I think that all of us have is that those products really don't target the underlying disease process per se. So that our goal rheumatologically is to stop the disease process. So it's trying to figure out how to balance all of these different factors together to really come up with the right answer.
Thank you. So switching gears, is there any advice for foot and toe pain?
For what's in?
For foot or toe pain?
Oh, for foot and yeah, and I'll never forget Dr. Rodnan, who was my mentor, would always say that a definition of a rheumatologist is a doctor who looks at your feet. And so we do look at your feet, but the feet, they have a lot of mechanical stresses placed on them. It's interesting that we have a lot of bones in there. We have our arches. There's a long arch, the longitudinal, and then there's the transverse arch. And those arches dissipate a lot of stress that's placed on our feet. But just like with other conditions or other areas of the body, like with low back pain, you have to know as much as possible of exactly where the pain is coming from. What's the pain generator? Is it coming from like the connections back there, like a plantar fasciitis? Is it coming, from a bunion that people have? It's interesting, when I see patients with bunions, I always ask them, so where did that come from? And, people always say, oh, my shoes or this or that. You know where bunions come from primarily? They come from heredity. Unfortunately, we inherit those. So, but again, the concept with foot pain or with difficulties with your lower extremities there, again, you want to focus on knowing exactly what the problem is and where the pain is coming from.
Great. And then that would help influence if there's a device or exercises that one could do then to support their feet, correct?
Right. Yeah. Well, yeah, there are devices that really can help with that, and I believe in that, that the proper cushioning of your foot can help dissipate the stresses that are placed on it. And again, that gets back to that concept of mechanical stresses placed on a joint.
Great. So next question, what are options for people living with pain that cannot take NSAIDs or cannot take steroids?
Right. There are certainly, when we look at treatment, we have pharmacologic treatment and non-pharmacologic treatment. Now, that's why focusing on activities of daily living, focusing on how we can perform what we need to perform without overly stressing our joints. We take a look at modalities such as the heat and the cold. We look at ways to strengthen our muscles so as to be able to reduce the amount of stress placed on our joints. There are lots of different treatments. And for example, when you take a look at steroids, yes, steroids can be given orally, but they also can be given by an injection. And that does tend to minimize significantly any of the systemic effects of the steroids. And, that would be another alternative. And it depends upon, with the non-steroidals, there are 21 different non-steroidal anti-inflammatory agents. And so, trying to figure out exactly what the uh, factors in a particular individual that would allow you to choose one agent or another.
So, what are your thoughts on platelet rich plasma
Yeah.
or prolotherapy?
Yeah. Again, those are procedures in which there are, there's been treatments, cortisone, actually cortisone was first introduced in 1949 at the Mayo Clinic. Actually, the person, Philip Hench, came to the University of Pittsburgh and then went to the Mayo Clinic, and he won the Nobel Prize for corticosteroids. And so that when we look at, and that was the beginning of injecting substances into the joints so as to be able to maximize the benefit, and to minimize any systemic effects on the rest of the body. So a number of different agents have been tried, and if we take a look at treatments such as the platelet rich plasma, and the Prolotherapies, these injections, either in joints or around joints, they still, it's a real challenge to know, because one of the problems is, unfortunately, with them, they tend to focus on osteoarthritis. And, when cartilage wears out, it wears out. So trying to see how the particular agent would influence the underlying disease process, is still under a lot of investigation. And hopefully we're going to learn more about it. And I wish I had a more specific answer, but, those are still investigational treatments. That's why, really promoting research being done on different treatments, so as to really determine, whether the treatment is efficacious, and then who should be given the treatment.
Great, thank you. Another question we have is, do you have any suggestions to help with pain and stiffness other than NSAIDs and heat?
Again, with this whole situation, with the, it really does come down. I spend my life focusing on and trying to help patients focus on understanding exactly what the problem is. And it really does take a lot of energy. And, there is the adage of listen to the patient and they will tell you what they have. And then you need to add to it examining that particular area. And then we have different studies, imaging studies with x-rays and more highly resolute studies such as CT scans or MRIs or some others as well. And so again, that is the concept that people really need to take away from this, is understand what the problem is, so we can understand to know what should be, what the possibilities are. I mean, if we look at osteoarthritis, for example, not that anyone is anxious to have surgery, but if the knee is worn out or the hip, the surgery, on the resurfacing of the knee or the replacement of the hip, it's interesting that those procedures have the greatest positive impact on quality of life of any elective surgery. So, they can be good. So, but that comes in understanding, the whole person, the individualized treatment, to be able to understand where the problem is located, and then why is it causing pain.
Right. And that segues into a question again, and I think we've sort of answered it already, but how long should someone endure pain before it's time to have a joint replacement?
Well, that's something that, there's the orthopedic surgeons, and, with our input and their primary care doctors, we need to determine, you take a look at the different factors. You take a look at, how the anatomy of the problem, how much of the joint cartilage, if any, is left. We need to take a look at the whole situation of the patient's medical circumstances. We need to take a look at their musculature, because one of the things, Heidi, that's so important is if you let these go too long, the surgery becomes much more difficult because the muscles, the motors of the joint, and the supporters of the joint become more and more weakened, and it makes it more difficult than to rehabilitate from the surgery.
Thank you. So we've got another question. Can osteoporosis cause pain?
Well, osteoporosis per se does not cause pain. It's when there is a fracture associated with osteoporosis. And, the osteoporosis, osteobone, porous, you get the weakening of the bone, the loss of the bone. It causes it to weak, and it really increases its susceptibility to fracture. And so pain per se with osteoporosis occurs when there's a fracture.
And how do I know if my pain is arthritis related?
Well, the again, I think these are really good questions, and they each of them have little different nuances, and they
Yeah.
kind of look at it from a different perspective. And it goes back, and I think everybody is getting the concept is you have to know what the problem is, and that's my responsibility, as your physician, to be your navigator to help understand what the problem is. I tell people this adage, which is true, is if you don't know where you're going, it's mighty hard to get there. And if you're shooting in the dark, you could shoot yourself in the foot. And I don't like doing that. So we really need to spend the time and energy to help understand what the nature of the problem is and then how to best treat it.
Yeah. And then as a patient, it's our role to make sure that we really clearly identify and share what exactly is happening, whether it's sharp pain or dull pain, when it happens, and come in prepared to answer those sorts of questions. Um, for someone with rheumatoid arthritis or inflammatory arthritis, what is your go-to pain strategy recommendation that is not a prescription?
So yeah, I mean, we do. I believe in in non-fire. Number one is education, is to help people, and that's where the Arthritis Foundation, can be such a resource for patients because understanding can help enormously the whole process of managing pain because you've got to understand what the problem is, and so as to what to do about it. Because if there is a lot of frustration that all of us can have by not understanding the problem. It's like when your car has a problem, if you have no idea what it is, then it's pretty frustrating. I mean, at least if you know what the problem is, you can understand what is being done to help correct the problem. And the same is true there because we do have, non-pharmacologic treatments. I must say that, you know, almost always though, there are some pharmacologic measures that can be added. And I really, from a holistic point of view, I mean, I really believe it sounds a little trite. I mean, the body has an enormous capacity to heal itself. What we need to do is just to enhance that capacity and the different factors that can impact that. So as really to allow the body to heal itself up.
Great. And then again, for our rheumatoid or inflammatory arthritis patients, who have you know, been on their medications for a while, and they notice that they're having more pain, like their pain isn't controlled. So, what's the process for switching disease-modifying drugs and/or increasing pain relievers?
Right. One thing that this whole concept of treat to target, the target being is to impact that disease generator really as completely as possible. And if we look at the new medicines for rheumatoid arthritis, the biologics and medicines similar to that, the so-called disease-modifying anti-rheumatic drugs for rheumatoid arthritis and other inflammatory diseases, the fact is that you would think that there would be an absolute predictability, but unfortunately there's a lot of variability of who responds to what. So there is I don't like the concept of trial and error. I look at it more as a therapeutic trial, defining parameters, understanding exactly what you're targeting, and then following closely to be able to assess whether the treatment has impacted the disease in a positive way without having any or to minimize any side effects.
Thank you. So I've got a disease-specific question for you. Since Sjögren's can be very difficult and oftentimes a long process to diagnose, how can those living with Sjögren's get the best possible care and treatment plan for their disease?
Right. It's interesting. When Henri Sjögren described this condition in the 1930s, the Sjögren syndrome is a condition in which the inflammation is occurring within glandular tissues. The ones most characteristics are there's a little gland here at the margin of the eye called the lacrimal gland. We have our salivary glands, our parotid glands here, our submandibular glands here. There are other glandular tissues in the body. And again, for reasons that we don't understand, there can be inflammation there. That inflammation can occur in association at times with other conditions like rheumatoid arthritis or lupus or other connective tissue diseases. And, it can be, it's a difficult problem to treat, and we do not have perfect drugs that actually target inflammation in those areas. And there's a great deal of research being done. Another factor involved with Sjögren syndrome is that you can have the inflammatory arthritis brought under control, but the Sjögren's may not be. And also, as we age, we get decreases in our hormone levels, estrogens, especially in women, and that can result in dryness, in different glandular areas. And aging is a challenge at times, dare I say, as we all know, and that something that that also contribute to the dry eye syndrome. But we do have, there are some specific medicines, the Restasis that can be used. There's some, medications that can be put in the eye that really can. Treating dry mouth is even more difficult, especially if it's intense.
Thank you. And I'll ask our last question, and I so appreciate your time today. Can the COVID-19 vaccines cause increased joint pain and sciatica?
Well, that's an interesting question as to what, first of all, these vaccines are unbelievable. The vast majority of people have very little problems. As in association with the immune stimulation with the vaccine, though, there can be, a little bit of aching, and you can get rashes, and, as to whether it really flares up the arthritis per se, it does not usually. And the vaccines are so unbelievably effective that, you can see, with what came out today of the CDC now making, I think, a really reasonable policy. If you've had your vaccine, your ability to be able to, kind of live a more normal life without the masks, except in specific circumstances. One of the challenges is that people who are immunocompromised. Now, the question is with the different medicines, that we have, there may be some effect, but the vast majority of people really don't have a problem the vaccines are a godsend. It's unbelievable, that the vaccine could be developed in such a rapid period of time and that it could be so effective.
Thank you. I really appreciate your time today, Dr. Sjögren, and your willingness to tackle this broad range of questions under a topic here.
It's a pleasure. As I tell patients, we, your healthcare professionals, we're here to serve. And if you look at the origin of the word doctor, it really comes from French, Latin, and it means teacher. And think doctor of philosophy, PhD, doctor of philosophy. I mean, we need to teach. I do a lot of teaching, and I teach the residents and students that, we need to help patients understand, because having an understanding of these conditions, it helps. It takes away that uncertainty, these mysteries. I think we can all deal with things much better when we have an understanding of kind of what the problem is, and that we can best know how to most effectively handle it, and how, the patient really can play their effective role, being the captain, being the director, and having to do what is most effective to help deal with the arthritis, and then to hopefully to get it to resolve, or certainly to decrease it as much as possible.
If you're curious about what our topic will be next month, visit the Live Yes online community at liveyes.arthritis.org on June 1st, and we'll reveal our next topic in Ask the Professionals Q&A. To learn more about the Arthritis Foundation and our awesome programs and services we provide, like our monthly patient education webinars, our podcasts, our connect groups, online community, and our insights program, visit arthritis.org. Thank you so much for joining us today.
Oh, thanks. Take care.